Hi, good evening, everyone. Hi, Hussein. Hi, Aisha. Hi, T. Welcome to today's session. Can everyone hear me loud and clear? Hi, Samira. Hi, Aisha. Hi, Fumi. Hi, Amboni. I really can't get everyone's name because some people are using different usernames. Well, so we'll just start right away. Just quickly go through some clinical questions and see how that can help us just revise and recall some things today. Okay, if you know anyone that needs to be on this session, you're free to send the link to them. Okay, all right. The first question: a 63-year-old man who comes into your pharmacy to ask about a rash that has developed over the past 24 hours. You take him to the consultation room and he shows you the rash on the left side of his abdomen. He says that he is recovering from a heavy cold and feels a bit run down. He's on indapamide and amlodipine. So what's the most likely cause of the patient's rash? Is it an allergy to his medication? Is it scabies? Is it streptococcus? Is it tinea? Or is it varicella zoster? If you have an answer, please type it in the chat box. What is the most likely cause of the patient's rash? What's the most likely cause of the patient's rash? Okay, I've got option E. Okay, so everyone agrees that this rash could be caused by varicella zoster. So what kind of rash would you say this is? What condition does the man have based on his symptoms? What condition does the man have based on his symptoms? Shingles, right? Yes, that's correct. Okay, this is shingles. So typical symptoms of shingles, rash, right? So what kind of rash? Is it unilateral or bilateral? What are you going to look out for in patients who present with shingles? Is it unilateral rash or bilateral rash? Yes, so you expect the rash to be on one side. Okay, you expect the rash to be on one side, unilateral rash. So I've also got, yes, one-sided rash, itching and burning sensation. That's also correct. Okay, so another thing you should also look out for is painful. Rash with shingles are usually painful. So itchy, painful, and burning kind of rash on one side of a patient's body. That's then you should be thinking of shingles really. Okay, so what's okay, so we've said it's caused by varicella zoster, which is correct. Okay, we've talked about the clinical presentation. So can shingles be treated over the counter or is it always a referral? So I've got pharmacy first in community. Okay, aside pharmacy first. Okay, can you treat it over the counter? What kind of medications would you give over the counter to help with shingles symptoms? Okay, so Abdul Rao said can give calamine lotion or Piriton, but not full control of symptoms. Okay, so now shingles can be treated over the counter, right? But some group of patients would need to be referred. Patients who are at high risk. Okay, patients who high risk patients would need to be referred. So what kind of patients would you classify as high risk? Because even when you're doing pharmacy first, you would have to go through some check boxes and refer some patients. So what group of patients will need to be referred? So I've got immunocompromised, that's correct. Okay. What other group of patients will need to be referred? Pregnant patients, okay? So immunosuppressed pregnant patients, okay? What about with regards patient's age? Facial involvement as well needs to be referred. What about with regards the patient's age? Yeah, so elderly patients, patients who are immunocompromised, right? So elderly patients really will need to be referred. Okay, so caused by varicella zoster. So generally, if you're not going to treat shingles over the counter, if you're not going to refer a patient with shingles, and you can treat it over the counter with medications like paracetamol, right? That can help with the pain the patient is experiencing. Urax cream as well can help. Antihistamines can help with the itch that the patient is experiencing. Okay, so on my list, I've got scabies as well. So what are the symptoms of scabies? What are the typical symptoms of scabies? So how would you know that this a patient has scabies? Full body itch at night. Okay, yes. Intense itching at night. The rash usually starts between the fingers. Yes, the rash usually starts between the fingers. Usually intense itching at night. Red spots, silvery lines. Okay. Yeah, so those are typical symptoms of scabies. Scabies is usually caused by mites, female mites. Okay. So in terms of treatment of scabies over the counter, what are we looking at? What are the treatment options for scabies? Treatment options for scabies. What cream are you going to recommend over the counter for scabies? Permethrin. Well done, Iman. Well done, Joy. Well done, Samira. Well done, Hussein. Permethrin brand name is Lyclair. Lyclair cream is usually recommended over the counter for shingles. Okay, so Lyclair cream. We've also got, aside Lyclair, we've got Malathion. Okay, Malathion cream, Lyclair cream. That's permethrin. Those are treatment options for scabies. Obviously, permethrin is first line because of issues due to resistance with malathion. So Lyclair cream, that's permethrin for scabies. And with scabies, how do they apply the cream? How should it be applied for treatment of scabies? Is it just on where the rash is localized? So Iman says apply on the whole body. Okay, full body, yes, from head down. So from head down, apply all over the body. Okay, scabies treatment, apply on the whole body. Leave overnight, usually for 8 to 12 hours. Okay, so that's important when you're counseling patients, including ears, face as well. So that's correct. And is it a one-off treatment? Treatment for scabies, is it a one-off treatment? Is it one-off? Or do they need to repeat treatment? Yeah, so repeat again after 7 days. It's 7 days, okay, not 2 weeks. 7 days. Repeat treatment after 7 days. So what other over-the-counter conditions would treatment need to be repeated aside scabies? Over the counter condition or over other condition would you need to encourage patients to repeat treatment? Okay, so Iman said tread warm. That's very good. So with tread warm, patients will need to repeat treatment after 2 weeks. What else aside tread warm? Aside tread warm, what else? What other condition? Head lice. Yeah, so with head lice, you repeat treatment after 7 days. With threadworm, you repeat treatment after 2 weeks. So T for threadworm, T for 2 weeks. T for threadworm, T for 2 weeks. So repeat treatment for threadworm after 2 weeks, and with scabies, repeat treatment after 7 days. Okay. So we said with scabies, we need to treat the whole family. Is that true or false? So when treating a patient for scabies, encourage the whole family to be treated. Is that true or false? Yes. So with scabies, the whole family should be treated. So with head lice as well, encourage patients to treat the whole family. Is that true or false? Yes, T for threadworm, T for 2 weeks. That's the way to remember it. So with head lice is false. Okay, remember no lice, no treatment. No lice, no treatment. So the patient needs to actually have head lice before you treat the patient. Okay, so it's not for prophylaxis. Okay, so while with scabies, you need to treat the whole family. What about with what about with so we've talked about scabies, threadworm, treat the whole family as well. Is that true? What are the exceptions? What are the exceptions? You might get a question in the exam that the patient is so age or the patient has a certain condition. Okay, so what condition or what are the exceptions in terms of treating the whole family for patients with threadworm? Pregnant women. So with threadworm, don't treat if the patient is pregnant, if the child is under 2 years of age. So you might get such questions in the exam. Okay, so that's why you should look out for the age and if the patient is pregnant. Also, mebendazole shouldn't be used in patients who have got epilepsy as well. So that's worth remembering as well. Okay, so we've talked about threadworm, we've revised scabies, we've revised head lice. What's your treatment option for head lice? What over-the-counter medication is available for treatment of head lice? Hedrin. What's the generic for hedrin? What's the generic for hedrin? Dimeticone. Thank you, Samira. So dimeticone, malathion can also be used, but dimeticone is preferred for head lice for because dimeticone is more tolerated as well in patients who have got asthma or other conditions. So hedrin, dimeticone is first line for head lice. So we've revised head lice, we've revised scabies, and we've revised shingles as well. We've also revised threadworm. So now I've got Streptococcus pyogenes on my screen. What kind of condition does this organism cause? Streptococcus. It's the known causative agent for what conditions? Okay. Yes, you guys are correct. So strep throats could be caused by Streptococcus pyogenes. Tonsillitis as well could be caused by Streptococcus pyogenes, impetigo and cellulitis. Okay, impetigo and cellulitis. Aside strep, what other organism will cause impetigo? What's the main causative organism for impetigo and cellulitis? What's the main causative organism for impetigo and cellulitis? Staphylococcus, yes. Staphylococcus aureus causes impetigo. Staphylococcus aureus causes cellulitis. Okay, they can also be caused by strep, but Staph aureus is one of the main causative organisms for impetigo. You might get a few questions like that in the exam. Oh, for example, pneumonia. I've seen pneumonia before. What's the main causative organism for pneumonia? Examples of causative organisms for pneumonia. Does anyone know? There are quite a number of them actually. Yeah, we've got strep pneumonia, that's correct. We've also got Klebsiella pneumonia. We've also got Mycoplasma pneumonia. There are quite a number. So it's what we're revising. We've got Haemophilus. Some of them are typical and some of them are atypical. Okay. So know the causative organisms for conditions like pneumonia. We've revised impetigo and cellulitis today. We've revised strep throat. It says strep throat is caused by strep pyrogens. And which other one? Um, there was one I was going to mention. I can't remember. Yeah, but know this ones: pneumonia, cellulitis, impetigo, strep throats. Okay, okay, UTI, obviously, everyone knows. What's the causative organism for UTI? What's the causative organism for UTI? E. coli, okay? E. coli is the causative, so that's what remembering because those are the kind of questions you might see in your exams. Okay, so we've talked about impetigo. Quick one before we move to the next slide. We said impetigo is caused by Staph aureus. There are two types of impetigo. We've got the bullous impetigo and non-bullous impetigo. So I'm going to ask true or false now. So bullous impetigo can be treated with hydrogen peroxide. Is that true or false? Bullous impetigo can be treated with hydrogen peroxide. Is that true or false? If it's a bullous impetigo. It's false, yes. Okay. So bullous impetigo should always be treated with an antibiotic, flucloxacillin. Okay, flucloxacillin is used for most skin and soft tissue infections like impetigo and cellulitis. Okay, but if it's bullous, definitely has to be treated with an antibiotic. You need to refer. And even if you're doing pharmacy first, bullous doesn't qualify for treatment in the pharmacy. You need to refer because it's a bit more complicated than non-bullous. Okay. However, if it's non-bullous, what are the treatment options? What are the two treatment options for non-bullous impetigo? Hydrogen peroxide and fusidic acid. Okay, hydrogen peroxide is usually first line. It all depends on if the rash is severe. Okay, if it's widespread, you might want to do fusidic acid cream. Another thing you should look out for is if the patient is unwell. So if the patient is systemically unwell, then you need to refer the patient for antibiotic, oral antibiotic, flucloxacillin. The patient is systemically unwell, high temperature and all of that. But if not, then you can just treat with hydrogen peroxide first line. I mean, if the impetigo is around the eye, then you can't give hydrogen peroxide. You need to give fusidic acid cream. Okay, that's what's remembering for you. So we've talked about that. All right, so I'll move to the next question now. Okay, so we've talked about shingles, vaccination, referral criteria, counseling points. What group of patients qualify for shingles vaccine? Does anyone know? From what age? Yeah, it's been changing to be honest. It used to be 70 to 79, but they're trying to incorporate people who are turning 65. So if you look at the NHS website now, it says adults who are turning 65. Okay. So it used to be 70 from 70 to 79, but they're trying to bring down the age threshold for shingles, but people who are older qualify for shingles vaccine really. We've talked about scabies. All right, next question. One of your regular patients visits you complaining of acute gout. He has a history of myocardial infarction 2 years ago and has no known drug allergies. He takes the following medications: aspirin, bisoprolol, ramipril, and simvastatin. Which of the following medications is the most appropriate treatment for him? A, B, C, D, or E? Now, before you give an answer, remember that the patient has acute gout, not chronic gout. Acute gout. So what's your treatment option for acute gout? So well done. The answer is colchicine. Okay, well done, everyone. Colchicine. Okay. For acute gouts, you either treat with NSAIDs or you treat with colchicine. For chronic gouts, allopurinol is the treatment option. Okay. Now the answer is colchicine. We can't give an NSAID because of the patient's history of myocardial infarction. So if you get a question in the exam, the patient has myocardial infarction or any cardiovascular condition, then you shouldn't really be prescribing an NSAID because of the last session we talked about NSAIDs and their cardiovascular side effects. Okay, I remember we mentioned that low dose ibuprofen has a low risk of cardiovascular complications. And which other NSAID has a low risk of cardiovascular complication aside low dose ibuprofen? Which other NSAID has a low risk of cardiovascular complication? Yes, well done, Iman and Simpac naproxen. Okay, naproxen. However, if you get a question in the exam, you don't want to be giving an NSAID when there's another option. Colchicine is the best option if the patient has a cardiovascular comorbidity. So the answer to this question is B. Okay, so before we move to the next question, we'll just quickly recap on colchicine. What's the dose of colchicine? So GMAT, if you get a question, you rather choose colchicine. So NSAID, for example, if the patient has uncontrolled hypertension, it does say that you should use NSAIDs with caution. For example, ibuprofen should be used with caution. So not necessarily a complete contraindication. Okay, it depends on the patient's case. So that's why when you're selling NSAIDs over the counter, you need to ask the patient if the patient has any other condition. So dose of colchicine, I've got 500 microgram 3 times a day for 3 days. Okay, so it's 2 to 4 times a day. Yes, even if the NSAID was naproxen or ibuprofen, still go for colchicine because colchicine is still safer than the rest. Okay, so 500 microgram 2 to 4 times a day for 3 days. Well done, well done, Aluko, well done, Hussein, well done, Iman, well done, Samita, and Angel Mary. 500 micrograms 2 to 4 times a day. Yes, that's correct. So maximum per course is 6 milligram. Maximum per course is 6 milligram. And we advise that patients do not repeat treatment within how many days? So do not repeat treatment within how many days? Yes, within 3 days. Treatment should not be repeated within 3 days. All right. So in terms of side effect, what major side effect of colchicine can you think of? A major side effect, very major. What major side effect of colchicine comes to mind? Blood disorders. Thank you, motion 3968. Blood disorders, blood dyscrasias. Colchicine can cause agranulocytosis. Okay, so symptoms like mouth ulcers and easy bruising. Okay, bleeding, those are symptoms of agranulocytosis, so it's worth remembering with colchicine. Okay, what side effects as well would indicate toxicity of colchicine? Early signs of toxicity. So if the patient experiences like abdominal pain, diarrhea, nausea, vomiting, those are symptoms of colchicine. Yes, thank you, motion. Yes. Okay, so those are symptoms of colchicine toxicity. So you might need to refer the patients. Okay. In terms of interactions, we've got a number of interactions with colchicine which you need to know. Can you think of any cardiovascular medication that would interact with colchicine? Statins, yes, simvastatin. So simvastatin and colchicine would increase the risk of myopathy. Okay. Any other one? So colchicine and digoxin as well. Cyclosporin is correct. Thank you, Jane. So colchicine and cyclosporin. Cyclosporin would increase exposure to colchicine. Colchicine and digoxin. No, colchicine and simvastatin. There's a main interaction with it. So I would say no. So don't forget colchicine and statin, colchicine and cyclosporin. I've got colchicine and digoxin. Okay, colchicine and digoxin as well. It could increase the patient's side effects. So with regards allopurinol, what's the common side effects that you can think of with regards allopurinol? Yeah, so what side effects will you look out for that might indicate that a patient has Steven Johnson syndrome? Rash, thank you for me. So allopurinol can cause rash, so can cause SGS. So if you would want to discontinue therapy. Okay, so you want to refer the patient if the patient experiences rash with allopurinol. Okay, indications. Can allopurinol be started during an acute gout attack? Allopurinol can be started during an acute gout attack. That's false. Yeah, shouldn't. So we've talked about very common side effects, rash, method of administration. How is allopurinol taken? Is it with food or is it after food? Is allopurinol taken with food or after food or before food? Is it taken with food or an empty stomach? Does anyone know? Yes, taken with or after food. Okay. What else? So allopurinol, remember, it should be taken with food. It should be taken with a full glass of water. It should be taken with a full glass of water. Those are the cautionary labels, label 21, label 27, and I've also got label 8. Do not stop taking this medicine unless your doctor tells you to. Okay, so with allopurinol, you want to refer them if they have any issues, um, like rash. You want to refer them to their GP. Yes, that's correct. If patient is already on allopurinol, it shouldn't be stopped. However, it shouldn't be started for the first time during an acute gout attack. Okay, so take with a full glass of water is a cautionary label with allopurinol. What other medication, what antibiotic do you also need to tell patients to take with a full glass of water? What antibiotic do you need to tell patients to take with a full glass of water? Doxycycline, that's correct, because it can cause esophageal irritation. All right. So patients with gout should also avoid high purine foods and alcohol. We talked about colchicine already. We talked about interaction with simvastatin. Also interact with digoxin, cyclosporin, clarithromycin, and ketoconazole. All right. The next question: what will be the most appropriate diagnostic test to request for these patients? Is it A, B, C, D, or E? So this patient has what condition? Swollen ankles, worse in the evening, breathlessness, fatigue. What condition is this? Heart failure. Thank you, Henry. So this is heart failure. With heart failure, the patient will have swelling, okay? Swelling of the ankles. Would you expect bilateral or unilateral swelling with heart failure? Would you expect bilateral or unilateral swelling with heart failure? Bilateral, okay. So breathlessness, that's due to accumulation of fluid in the lungs, fatigue. These are symptoms of heart failure. Pro-BNP, pro-B type natriuretic peptide, is an enzyme that is released due to ventricular stress. Okay, so would expect an elevated pro-BNP in patients with heart failure. So the answer is D. So quick recap of on heart failure. There's obviously a new guidelines on the management of heart failure. Okay, we've got BAMS, BAMS. Okay, so B stands for beta blockers, A stands for ACEIs or ARB, M stands for mineralocorticoid antagonist, and S stands for SGLT2 inhibitors. So the new guideline says that this therapy should be initiated almost immediately within a couple of weeks, okay? Because it's been shown that all these therapies have their own individual roles in reducing mortality in patients with heart failure. So this is the new guideline for the management of heart failure, really. Okay. So if the patient does not experience relief, what other add-on medications can we give aside BAMS? Yeah, team pack, but really it's just similar medications. The only difference is that these medications are the four pillars that we expect to be started in patients with heart failure. Instead of starting them one by one, we expect all four to be used. Okay. So Henry said furosemide loop diuretics, that's for symptomatic relief. Okay. For symptomatic relief, we would use loop diuretics. But for actual treatment, what are the add-on medications that can be used for actual treatments? Yeah, Entresto. Entresto, what's the generic? Entresto is sacubitril stroke valsartan. So if we're going to start sacubitril stroke valsartan, which of these medications would we need to stop? Because obviously we can't use them together. Which of these medications would we need to stop? Is it the beta blocker or the ACEI or the mineralocorticoid? Yes, because ACEIs and sacubitril they work the same way. Okay, sacubitril stroke valsartan, I think that's ARNI. So they work the same way. So really, you need to stop the ACEI if the patient is going to start on ARNI. Okay. So what else? Hydralazine and nitrates. What group of patients would we recommend hydralazine and nitrates for? A combination of hydralazine and nitrates. What group of patients? Hydralazine plus nitrates. Yes, that's correct, Jean and Samira and Joy. Patients who are of Afro-Caribbean origin that might not tolerate ACEIs. So for such patients, hydralazine plus nitrates is recommended. We've got digoxin as well. Digoxin just helps with, it doesn't help to improve mortality, it just helps to reduce hospitalization in patients with heart failure. Okay, so that's the summary in terms of treatment. In terms of non-pharmacological management, salt intake should be what amount of salt do we advise patients to take? How many grams of salt? 6 gram. Okay, less than 6 gram of salt a day. So alcohol 14 units. Okay, alcohol 14 units spread over 3 days. So obviously you need to encourage patients to monitor their weight every single day. Okay, so just to clarify, everybody should try and make sure that you're on the live page, so you're not answering questions that were asked before. So just check to make sure that you are live. So 6 grams of salt. What vaccines do we recommend in patients with heart failure? Yes, that's correct. Iman and Joy. Pneumococcal vaccine and flu vaccine is recommended in patients with heart failure. Okay, how often is influenza vaccine given? Is it annually, or is it every 2 years, or is it every 6 months? What's the frequency for flu vaccines? Yearly, yeah. Flu vaccine is usually given during the winter period, like now. The flu vaccine campaign is ongoing. Okay, so yearly. All right. Obviously, encourage patients to monitor their weight as well. Report weight of 1.5 to 2 kg in 2 days. Weight gain of 1.5 to 2 kg in 2 days. All right. So next question, question 4. Six-year-old woman with bipolar disorder. She has been stable on lithium. Her most recent lithium level is 1.1. She's on hydrochlorothiazide and ramipril. Which of the following is the most appropriate next step in a management? A, B, C, D, or E? So really, what would you advise? Would you advise the patient to stop her blood pressure medication just by yourself? And then what would happen next? Yes, so you want to encourage her to seek medical advice and withhold lithium. So C is correct. Okay, withhold lithium and arrange urgent medical review. C is the right answer. Okay, so obviously ramipril and hydrochlorothiazide could be the reason why she's experiencing. It's most likely the reason why she's experiencing lithium toxicity, because ACEIs and thiazide diuretics can affect the kidney. ACEIs most especially, and could lead to reduced renal excretion of lithium and increased lithium toxicity. So advise her to arrange urgent medical review. C is the right answer. So we'll quickly recap lithium. Side effects of lithium. Which ones can you remember? So medications that you shouldn't really stop. You shouldn't really stop anti-epileptics abruptly. You shouldn't really stop antipsychotics abruptly. Okay? But I mean, the most ideal option in this case is to ask her to seek urgent medical review, refer her to the GP, And that's the only option that points to that direction. So C is most appropriate. So I've got lower seizure threshold, impaired renal function, thyroid disorders, increased intracranial pressure, QT prolongation, rhabdomyolysis. Thank you, Iman. Okay, so I've got a mnemonic for you to remember: BLURG. B is for. So now I'm talking about side effects. Okay, not necessarily symptoms of toxicity. Okay, so we've got bone marrow suppression. What organ does lithium affect? It starts with L. Yeah, actually, lithium with lithium you would need to do what's the word now? You need to do full blood count as well, total blood count. So that's what the B is for. Okay, but with lithium, sorry, L is not L isn't among. So we've got kidney, not liver. Okay, lithium affects the kidney, not the liver. Apologies. So renal function R is for lithium. Okay, so what other side effects of lithium can you think of? Or what other monitoring requirements? What other side effects can you think of? So renal function needs to be done. Full blood count needs to be done. What else? Thyroid, yes. Thyroid function test. Does lithium cause hypo or hyperthyroidism? Weight. Thank you, Shobandi. So what's the effect of lithium on weight? Is it weight gain or weight loss? Yeah, so lithium causes hypothyroidism. What's the effect of lithium on weight? Weight gain. Yes, lithium causes weight gain. Okay, lithium causes weight gain. So because lithium affects the kidney, we need to do U&Es, urea and electrolyte test. We need to do EGFR as well. We need to do thyroid function. We need to do full blood counts as well, weight stroke BMI and ECG. These are the monitoring requirements for lithium. So what you should use to remember this one is RCT, BTW. So R for renal, C for cardiac, which is ECG, T for thyroid function, B for BMI, T for total blood count, and then weekly. Lithium levels need to be monitored weekly. And what did we say is the target level? What's the target concentration? What's the plasma target concentration? Yeah, if you remember hypothyroidism, you can as well remember weight gain for lithium. Yes, 0.4 to 1. Okay, 0.4 to 1. That's the target plasma concentration for lithium. So lithium and sertraline, is there an interaction? Lithium and sertraline, is there an interaction? Yes, those two medications can cause serotonin syndrome because both drugs increase the serotonin activity in the brain. Okay, so that's it for lithium. In terms of interaction, drugs that may interact with lithium, we've mentioned sertraline already. We've mentioned ACEIs. What else? Examples of medications that could interact with lithium: thiazide diuretics, yes, thiazide diuretics will affect the kidney, NSAIDs, AC inhibitors, and ARBs. Okay, what's the effect of metronidazole on lithium? Lithium and metronidazole, is there an interaction? Lithium and metronidazole, is there an interaction? Yes, metronidazole is an enzyme inhibitor, so it could increase the concentration of lithium. Okay, so thiazide diuretics, drugs affecting the kidney, thiazide diuretics, NSAIDs, ACEIs. We've talked about sertraline, could increase the risk of serotonin syndrome. We've also mentioned metronidazole as well. So counseling advice avoid over-the-counter NSAIDs, which could lead to lithium toxicity. Is it hyponatremia or hypernatremia? Which could lead to lithium toxicity. Is it hyponatremia or hypernatremia? Hypo, yes. So that's why we advise patients to avoid sudden changes in diet containing sodium. Also advise patients to avoid low sodium diets. Okay, because lithium and sodium compete for renal excretion. So advise patients to avoid low sodium diets and to stay well hydrated. All right. What conditions would you usually see lithium being used to treat? Indications. What are the possible indications? Bipolar disorder, okay? Can lithium be used for depression? Yes. Is that first line for depression, or when is lithium used for depression? So you can only use it when you need to augment therapy for augmentation, okay? Not first line. So what's first line? What's your first line antidepressants? Yes, that's correct, Christine. So you use it for when you need to add an additional antidepressant. So you can augment with lithium or with an antidepressant. So yes, SSRI is a first line. All right then. So we'll move to the next question now. Oh, I didn't ask about symptoms of lithium toxicity. So we've got fine tremor, nausea, vomiting, diarrhea, thirst, polyuria, and mild drowsiness. Of course, we've got blurred vision as well. And in severe cases, we've got seizures. Okay, so these are symptoms of lithium toxicity. Fine tremor, nausea, and vomiting. What other medication has similar toxicity symptoms with this? You know what medication also has this signs of toxicity? Yes, digoxin. Okay, digoxin could also have similar signs of toxicity. And how would you differentiate between signs of lithium toxicity and signs of digoxin toxicity? What's the key word to look out for with regards digoxin toxicity? With regards digoxin toxicity, what kind of vision? would you expect? The eyes, okay, what would you expect? Yes, yellow vision with digoxin. Okay, yellow vision with digoxin. Okay, so ideally, lithium should not be stopped suddenly. I think someone asked the question. So if we go back to this question, ideally, lithium should not be stopped suddenly. Okay, but obviously we need to look for the most appropriate option. What's the most appropriate next step? We're not going to increase the lithium dose. We're not just going to advise the patient to stop taking ramipril and hydrochlorothiazide because at this time this patient is experiencing lithium toxicity. Okay, so there's a reason why we might need to withhold lithium. Okay, but the best option is actually to refer the patient. But in this question, option C is most appropriate, not just advising the patients to stop taking ramipril and hydrochlorothiazide because we need to deal with the toxicity symptoms that the patient is experiencing. Okay, so let's go back. Let's move to question 5. Yeah, we literally just did this question in our group chat today. If you're not on the group chat, please indicate so you can be added. Okay, so we methotrexate. Female patients would need to use effective contraception during treatment and for at least 6 months after the treatment ends. And we said for males, how many months? Yeah, so 3 months for males and 6 months for females. So the answer to this question is methotrexate. So which other medications are teratogenic on my screen, on my list? What other medications are teratogenic? So mycophenolate is teratogenic. That's correct. Okay. Mycophenolate is teratogenic. So which of them actually have a pregnancy prevention program requirements? Which of them actually have a pregnancy prevention program requirements? Yes, mycophenolate has pregnancy prevention program requirements. Okay. Topiramate is also correct. So aside mycophenolate and topiramate, which other medication has a pregnancy prevention program requirements? Aside mycophenolate, topiramate, sodium valproate. Okay, there's one I'm looking for, used for acne. Used for acne. Which one? Isotretinoin. That's correct. Isotretinoin. Okay. So let's quickly revise the pregnancy prevention program requirements. We've talked about methotrexate 6 months for males and 3 months for females. Avoid use effective contraception 6 months after the treatment ends and 3 months for males. Okay. So what about mycophenolate? What about mycophenolates? How many months would patient need to use contraception for after treatment? For patients on mycophenolates, so 90 days, is that for every single person? Is that for both males and females? So I've got 6 weeks for females and 90 days for males. Okay, So for mycophenolates, advise patients to use contraception 6 weeks for females and 90 days for males. Okay. What about isotretinoin? How long will patient need to wait before getting pregnant for isotretinoin? So Asha, Tim Park, Jane, and Iman said 1 month after. That's correct. So for isotretinoin, wait 1 month. Use effective contraception for 1 month. Okay, after stopping. For methotrexate, use effective contraception 3 months for males and 6 months for females. While for mycophenolate, 6 weeks for females and 90 days for males. Okay, you're most likely going to get asked on maybe methotrexate or isotretinoin, not mycophenolate, but it's still worth remembering as well that mycophenolate is teratogenic. Okay, so let's quickly look at this. Okay, so they're all teratogenic. Methotrexate, we don't require pregnancy prevention program. So both males and females need effective contraception for methotrexate and mycophenolate, but only females for isotretinoin. Okay, so when we say two effective methods for isotretinoin, what do we mean? What kind of contraception methods are effective? Is it the long-acting ones? Is it the barrier methods? What contraception methods are said to be effective? What contraception methods are said to be effective? So we should either use a long-acting contraception like copper IUD, or we use two complementary user-dependent forms of contraception. The user-dependent forms of contraception are the ones that are user-dependent, such that if you don't remember to take your oral contraceptives, that could affect and that you could the patient might get pregnant. However, a longer acting one is user independent like copper IUD. So we advise patients to use one highly effective method of contraception or user one user independent form or two user dependent forms of contraception. That's a requirement for isotretinoin. And that also applies to sodium valproate as well. Okay, so pregnancy test should be done monthly. What's the validity of a prescription for isotretinoin in a woman who is on PPP? How long is a prescription valid for? Yes, prescription is valid for 7 days. Okay, prescription is valid for 7 days. Well done, well done, well done, everyone. All right, so moving on to the next question. Okay, toxicity of methotrexate. We've talked about this several times. Bone marrow suppression. We said lithium affects the kidney. Okay, renal toxicity with lithium. However, with methotrexate, liver toxicity and renal toxicity and also respiratory toxicity. Okay, so liver, respiratory and renal toxicity and gastrointestinal toxicity for methotrexate. So this is what remember. We discussed this at the last session. That's why I'm not going to dwell too much on it. Trimethoprim causes bone marrow suppression with methotrexate, NSAIDs and aspirin as well. Okay, azathioprine. What the key side effects to remember with azathioprine? What's the key side effects to remember with azathioprine? Bone marrow suppression. Yes, thank you, Jane. Okay, so which gout medication does azathioprine interact with? What gout medication does azathioprine interact with? Allopurinol, yes. So we advise, because allopurinol is a xanthine oxidase inhibitor. It inhibits the metabolism of azathioprine. So we advise patients to reduce the dose. So are we reducing the dose to 25% or by 25%? Because every people get that confused all the time. We are reducing the dose to one quarter, which is to 25%. Okay, so manufacturer advises reduce the dose to one quarter of the usual dose when used concurrently with allopurinol. So reduce to 25%, not to 75%. Reduce the dose to 25% of the usual dose. I hope everyone gets that. Reduce the dose to one quarter of the usual dose. Okay, so monitoring requirements. Hepatic function needs to be monitored. Okay, what are the monitoring requirements for azathioprine? Full blood counts, yes, because it causes myelosuppression. So full blood counts needs to be monitored throughout treatments. Okay, so let's move to the next question. A 61-year-old female. Yes, Francine, that's correct. Reduce azathioprine to 25%, that's correct. Everyone should make sure that they are live on this chart. Okay, so a 61-year-old female for postmenopausal osteoporosis prevention, eating a healthy, balanced diet, no menopausal symptoms. Which drug is most appropriate for her? 61-year-old female for postmenopausal osteoporosis. Which drug is most appropriate for her treatments? Yes, the answer is risedronate. Risedronate is first line. Okay, risedronate is first line for osteoporosis. Okay, bisphosphonates are first line. So with regards risedronates, renal impairments. Can risedronates be used in patients with renal impairments? At what EGFR do we discontinue risedronates? At what EGFR do we discontinue risedronates? Yeah, so these are the things you should look out for. Risedronate and alendronic acid, they have different EGFR threshold. Okay, so that's what you should look out for. Okay, all right then. Finally, last question. This is the last question for today. A patient with diet control type 2 diabetes, HbA1c is 83. He now requires medications to control his condition. Which medication is best? So resedronate should be avoided if the creatinine clearance is less than 30 ml per minute. Okay, so well done everyone. The answer to this question is metformin. Metformin is first line for treatment of diabetes. Okay, metformin is first line for treatment of diabetes. All right, so I would have to stop here today. We're going to continue this weekend. For those that have signed up for our intensive classes would continue. I'm going to post the link on the comment section so that everyone can access it in case you want to sign up. So how did everyone find today's session? All right then, well done everyone. Thank you for joining and have enjoy the rest of your day. Bye bye.